today we're going to talk about cytoreductive surgery in kidney cancer, which has been part of the history of surgery for kidney cancer for many years. Few numbers just to put things in perspective. About a third of patients we see at presentation with kidney cancer can be metastatic, and then about up to 40% of the one who are presenting localized disease can then develop metastatic disease. And these with metastatic disease, they can have a very bad prognosis. Estimated 5-year survival are about 5%, and median survival time less than a year. This is, of course, older data. And therefore, there has been traditional rationale in this patient to perform cytoreductive surgery. Now, the concept of cytoreductive surgery or the bulking surgery, which is also used in other type of cancers, is basically the resection of the primary tumor despite the presence of concomitant metastatic sites. The assumption of doing this is that the procedure should be feasible and safe for the patient. And the goal is, of course, the ultimate goal is to improve the overall and cancer-specific survival, but also to prevent some symptoms that the patient might develop in the future, and also to improve the immunologic response to the tumor. Now, it's not really clear what's the mechanism of action of cytoreductive surgery in kidney cancer. However, they've done some studies in the past, and so some theories or proposed mechanisms are out there. The main one is the immunologic mechanism. Basically, the primary mass is thought to be working as an immunologic sink, attracting immunologic cells, and therefore the immune reaction elsewhere is suppressed that way. Also, the primary tumor is thought to produce immunosuppressive factors. Therefore, if you remove the primary tumor, you have a benefit, double benefit from an immunologic standpoint. Also, there is a non-immunologic therapy. By removing a kidney, you create a metabolic acidosis, mild metabolic acidosis, and therefore this can basically modify the microenvironment for the tumor, and therefore inhibiting the invasiveness of the tumor. Again, these are theories more than a fact. Now, in the immunotherapy era, and we all know that there were two well-done randomized trials. One was the SWOG trial, and the other one was the EORTC trial. They were both published in 2001. They did Flanagan reported a meta-analysis of the two studies a few years later. Basically, the overall overall number was that there was an improved survival by about 6 months and a reduction in the risk of death by 30%. So those led to the kind of adopt cytoreductive nephrectomy as a standard. So patients were doing cytoreductive nephrectomy and interferon were doing better than those without interferon. This was kind of the paradigm. However, things has changed, as you know, over the past 10 years. There has been a total revolution in the field of systemic treatment of kidney cancer, starting with sunitinib. Many other drugs have been have hit the market, and all of them working in at different molecular level. PDGF receptor, VEGF receptor, PDL1 that are now used also for bladder cancer, and therefore this has totally changed the scenario. Also, in terms of systemic therapy, the recommendation is not as easy as they were in the past. You can have a first line, second line, third line therapy, and things are changing almost on a yearly basis for these patients. These have made things more complicated because we know we have more weapons, so we can think of different approaches for the cancer. So you can think of doing a nephrectomy and then a targeted therapy, or you can do just a surgical treatment if everything is resectable, or you can do a therapy and then do a nephrectomy, or you can just think, well, we can just do a targeted therapy, which could be effective. So we really don't know which the best way to go is. After the approval of the targeted, the TKIs drugs, has been some studies, population-based studies, have shown that there's been a decline. This is the year, 2005 was the year when the first of these drugs were introduced on the market. There was a decline in the use of cytoreductive nephrectomy in the United States. And so why this? Why people decide not to use anymore, have decided not to use any more cytoreductive nephrectomy? Because of some concerns. One could be the surgical morbidity. Then the other could be which is connected to this second point, which is surgical morbidity can translate in missing the train for a targeted therapy. And also studies suggest, there are some studies, small studies suggesting that there might be no benefit if doing surgery in this patient. And certainly there is a lack of level 1 evidence as we had for immunotherapy, which was, as I showed you before. Now, let's put, talking about the first of these points, this is a series from the Mayo Clinic. Basically, they put together about 300 cases with metastatic renal cell carcinoma treated initially in the immunotherapy era, and then also the last cases were done in the targeted therapy era. And these are patients with minimal metastatic burden. And they were more focused on the morbidity, surgical morbidity of these patients. Complication rate, as you can see, was 12%, major complication rate 5%, and the cases where the surgery basically delayed the start of the systemic therapy was estimated in 10%. They also said that liver metastases, intraoperative transfusion, and presence of pathologic positive nodes were associated with higher morbidity. Another study from UK, also almost about 300 cases, a very good performance status. The mortality rate was actually quite low, and this is national data from UK. Also, if you look at complication, post-operative complication a little bit higher than the previous study, climbing 3 and higher, 8%. And also here they calculated risk factor for adverse events, larger tumor site or higher number of metastatic sites. This other study, this is a multi-center study, Fox Chase and Hershey Medical Center. 140 patients underwent cytoreductive nephrectomy, and about a third of them did not receive systemic therapy after cytoreductive nephrectomy, and of these, a third did not receive it because of the rapidly progressive disease. In other words, the patient had nephrectomy, but when there was time to give after nephrectomy, the systemic therapy was too late already. So those patients probably lost the train for chance to be treated effectively with systemic therapy. And therefore, the conclusion of these authors are that we should identify patients high risk of rapid progression that are probably not a good candidate for cytoreductive nephrectomy. What is the oncological impact of these of the cytoreductive surgery for this patient? As I said, there is no level 1 evidence, no randomized trial available yet, but there are some multi-center series, some population-based studies on large databases, and I know that meta-analysis is not the optimal thing, but they can give us a general idea. This is a recent one where they put together all the studies done recently so therefore these are studies done in the targeted therapy era, and mostly with sunitinib, and they show basically the patient with cytoreductive nephrectomy did actually better in terms of overall mortality. This is another study which is the largest available so far in this field, a retrospective analysis, 20 center, 1,600 cases. Some of them received cytoreductive nephrectomy, the other group did not receive, and as you can see from the curves here, the median overall survival was better for the one who received cytoreductive nephrectomy, and with the other ratio of 0.66, yes. So interesting in this study, what they look is at the incremental, what they define as incremental overall survival benefit of doing surgery. So basically, they divided patients based on how long they survived, and they noticed that there is a benefit, this is in months, so the highest benefit was those who survived up to 2 years, and you have a 5-month benefit in overall survival. Those who did not survive, who survived who had the overall survival less than 3 months, the benefits was really non-statistically significant, as you can see, and really minimal. And therefore, they basically say the shorter is the prognosis of the patient, the worse is prognosis of the patient, the less effective is the benefit that surgery can give to the patient. They also analyze this based on the prognostic factor. These are the prognostic factors they consider, and they notice that basically the cutoff point is at 3 prognostic factor. So if the patient have more than 3 or 4 and higher of these prognostic factor, they don't receive any benefit by doing a cytoreductive nephrectomy. And as we will see later, this is important because basically, yes, cytoreductive nephrectomy may provide overall survival benefit, but only selected candidate. And the problem is how to select these patients, how to identify these patients. And well, to answer this question, there have been some prognostic model. This is a well-known, the Memorial Sloan Kettering model has been proposed, has been constructed in the immunotherapy era, and where they consider this factor, the performance status, the time from diagnosis to systemic treatment, the hemoglobin levels, LDH, and also the calcium levels. And the score is also known as Mozart score, but based on how many of these factors the patient have, they could be divided in favorable, intermediate, in 3 groups, risk groups. And this was, again, done on a series from the immunotherapy era. A newer prognostic model was the one proposed by the MD Anderson, where they also considered these risk factors, and this is more also here 3 risk factor or less is a good thing, more than 4 is a bad thing. So this is another tool that can be used to select patients for cytoreductive nephrectomy. Other question is, okay, there might be some benefits for cytoreductive nephrectomy for some patients, but when you have to do surgery, you start with therapy and then you do surgery, or the other way around. And there are not so many studies on this. This is from UCSD. They did a small study, 35 patients. One group had cytoreductive nephrectomy followed by sunitinib. The other had sunitinib and then cytoreductive nephrectomy if there was a response to the therapy, or they just got a second-line systemic therapy if they progressed. And they noticed that in group with the outcomes were better in those with who had cytoreductive nephrectomy selected that way. If you want to look at surgical morbidity from the other side, is the problem that if you do surgery after TKI, you might have more problems, more risk of complication because of several reasons. In preparation for surgery, the patient might be anemic, might have thrombocytopenia or neutropenia, so you have to address this issue before proceeding for surgery. From an aesthetic standpoint, there might be some cardiovascular issue, there might be intraoperatively a high risk of hemorrhage because of fibrosis of adhesions. Also, there might be some postoperative issue, such as delayed wound healing that has been reported in these cases. And therefore, also this is another piece of the puzzle you have to consider when you approach this patient. Now we talked about, of course, we assumed we were talking about radical surgery, radical nephrectomy, but there are also some evidence on nephron-sparing surgery. Of course, this is nephron-sparing surgery done on for imperative indication, patient with solitary kidney. There is a very limited handful number of reports on this. The rationale is, of course, if you can preserve some kidney function, then this patient might get some systemic, have enough kidney function to get systemic therapy after. There are really, again, very limited data. This is probably the first series from the Mayo Clinic. As you can see, very low number of patients, 60 patients, most of them with a solitary kidney and single metastasis, which were they tried to also to resect the metastasis, and the cancer predictive survival 5 years was about 50%, so not bad if you consider the term metastatic patients. Also, larger data from a multi-center study, which was published a few years later in Cancer, 17 institutions, they were able to collect 45 cases that were treated with Nephron Spanish surgery, which represented about 6% of the entire cohort of patients they had. They matched pair with the 99 cases of radical nephrectomy patient, and they saw that there was no difference in terms of cancer-specific survival. This is the multivariate analysis. As you can see here, the p-value is not significant. Of course, significant are other factors such as grade and stage and grade of the cancer. So basically, as you can see from the title, Nephron Spanish surgery in some cases does not compromise disease-specific survival in this patient. And then there are also some population-based data, SEER data. Capitano reported this study, and then also Hallenthal this other study, and therefore, they say that partial nephrectomy can be an option when there is an imperative indication of saving the kidney for these patients. What are the guidelines recommendations? These are the EAU guidelines recommendation, recent, and they define that they basically state that only patients with solitary oligometastatic, so low volume metastatic disease should have a cytoreductive nephrectomy, whereas patients with a short life expectancy and poor risk disease are probably unlikely to benefit, to have a benefit from the surgery. And prognostic model should be defined patient by case by case, should be used on a case by case basis to define which patient should get the surgery. Also, the NCCN guidelines basically they state the same concept. Those who are most likely to benefit from cytoreductive nephrectomy before systemic therapy, so as a first step of the multimodal treatment, are those who have lung-only metastases, good prognostic factor, and good performance status. And therefore, the questions that are kind of still open, I mean, we don't really have the definitive answer if the surgery in the targeted therapy era prolongs survival, the timing before or after, and how we can optimally select the patient. We don't know the answer to this. There are some experts who have proposed some algorithm. For example, this is from Axel Becks from the Netherlands. Basically, if you have a metastatic patient where the tumor is resectable and you have a favorable prognosis, you can think of doing a cytoreductive nephrectomy, whereas if the prognosis is poor, you should go for targeted therapy. If the complete resection is not possible, again, you can use another tool to risk stratify the patient, and here you can think of doing a cytoreductive nephrectomy and then do a first-line systemic therapy. This is, of course, not the dogma, but it can be a way of approaching the problem. I think the answer probably will come from some of the ongoing randomized trial. Well, this is Carmina trial, where basically a question, they try to answer a simple question: is better to do a nephrectomy and sunnitinib or just a sunnitinib? And they are trying to the target is to enroll about 500 patients. However, the recruitment was not easy. In the UK, was closed after 4 years. They continue to recruit in France. We probably might have some data coming up in the next couple of years. The third time trial is another trial done by the EORTC. Also, they had trouble with the recruitment of this patient. This answered another question, which is, okay, we do both. We do nephrectomy and systemic therapy. Should we do the nephrectomy first and then the systemic therapy, or the other way around? And again, about 500 patients, that's the target for the patient enrollment, but the study was closed earlier and probably is underpowered to show some differences in, and therefore, this is one of the editorial accompanying which recently appeared in the European Urology, saying maybe these studies might not give us any answer actually. So the role of cytoreductive nephrectomy deserves further evaluation because the current evidence, there is no evidence, level 1 evidence, and I think the question are timing, patient selection. Hopefully we will have some data from ongoing randomized trial, but certainly should be considered as a tool in the multimodal approach of metastatic renal cell carcinoma. Thanks.